Hello viewers, today we will be discussing about supraventricular tachycardias, and since these are commonly seen in clinical practice, so we will learn about few parameters and the features which can lead us to make the diagnosis of one of the supraventricular tachycardias. We know that there are three types of supraventricular tachycardias or SVTs that are seen in clinical practice, and these are the AVNRT, the AVRT, and the AT. So there are some features in the ECG. If we can see them, we can clearly make a firm diagnosis of one of them. So let's discuss the ECG now. In the ECG, what we can see is that on the left hand side, there is some rhythm that is going on which is regular, and on the right hand side, there appears to be a tachycardia. So this is basically a sinus rhythm that was going on because we can see that the P wave morphology and the axis is just like a sinus beat, and the firing rate of the sinus beat is within the limits. So it is a normal sinus rhythm that is going on. Now something happened over here which leads to this tachycardia, and this is a supraventricular tachycardia because it is a regular and a narrow complex tachycardia, and this helps in the diagnosis of making a supraventricular tachycardia. Now, there are some features in the ECG which can lead to the firm diagnosis of one of these. So, now we'll discuss these. The most important point to understand whenever there is a tachycardia is if by any chance you get to see how it is initiated, then this is very important. So here in the ECG, we could see the start of the tachycardia or tachycardia initiation, and this is encircled with this red circle. So now let's have a look on this. I have zoomed in on the point where the sinus rhythm has transitioned to the tachycardia. In a normal conduction that goes on routinely, we can see that the sinus beat goes over the fast pathway and produces a QRS complex, and this is shown over here. So this is the sinus beat that goes down into the AV node through the fast pathway. Now look at over here, we can see that there is an ectopic P wave because the morphology is changed as compared to the sinus P wave. Now over here, this ectopic P wave has conducted onto the QRS with a longer PR interval, and this happened because there was a block in the fast pathway and there was conduction over another pathway, and that what is called as the slow pathway. Sometimes what happens is that whenever there is conduction over the slow pathway, this pathway, the fast pathway, it is not refractory and it has the tendency to conduct retrogradely as well. This means that normally it conducts antigradely from the sinus node to the AV node, but in some conditions, if there is a milieu, the conduction goes retrograde as well. So in this case, what happened was that the conduction over the fast pathway goes up retrogradely, and we can see it over here as marked by the arrow. So this was conduction over the slow pathway followed by a retrograde conduction of the fast pathway, and whenever there is this thing happening, this produces a circuit, and this is a re-entrant circuit of a AVNRT. So this is a case of an AVNRT, and more specifically a typical AVNRT, which means that the antigrade conduction goes over the slow pathway and the retrograde conduction goes over the fast pathway, and this then continues to goes on and becomes a re-entrant circuit of a typical AVNRT.